I'm Doug Zipes, and I'm part of the writing committee of the paper published today titled Eligibility and Disqualification Recommendations for Competitive Athletes with Cardiovascular Abnormalities. This is a sequel to three previous Bethesda conferences, numbers 16, 26, and 36, and follows the last one by some 10 years or so, since it was published in 2005, and is an update on the recommendations for competitive athletes who have cardiovascular abnormalities. We chose to update this because there have been significant changes both in our recognition of some inherited arrhythmia syndromes that may put the athlete at risk for sudden death, as well as recognition that the competitive athlete group is expanding with younger people participating as well as older people participating, and particularly in the latter group are adults with corrected congenital heart disease. There have also been a number of publications that deal with athletes who have cardiovascular abnormalities that made us rethink the recommendations and liberalize them in at least two important areas. One is in the congenital long QT syndrome, and the other is in athletes who have implantable devices, namely pacemakers and defibrillators. And we've liberalized our recommendations in both of those categories. It's important to remember that the goal of this publication for healthcare providers is to maintain the safety of athletes. Sudden cardiac arrest in athletes is fortunately an uncommon event, and we want to make sure that it remains at the lowest level that is possible. Ultimately, however, decisions for athletes with heart disease to compete remains with the caring physician. And it is important that that doctor interact with the athlete and discuss the potential risks and benefits. We well recognize the importance of athletics, and particularly competitive athletics. And for some athletes, this is their entire life. So we obviously don't want to recommend restriction that obviously will impact significantly on the athlete's life, while nevertheless reminding ourselves that the care of the athlete, his or her health and safety, is our prime goal. But ultimately, the final decision is for the caring physician interacting with the athlete to make that final recommendation. These are only recommendations, and the caring physician is the final arbiter. And when he or she feels that a decision is different from the recommendations, so be it, as long as there's valid justification for such a decision. We hope that these guidelines will be usable and helpful for physicians taking care of athletes with cardiovascular abnormalities.